For the next speaker, I'm very happy to welcome back again to Cedars-Sinai one of my dear colleagues, Dr. Alan Rozanski. Alan has been one of the major forces in Cedars-Sinai's productivity in our non-invasive imaging in nuclear cardiology and cardiac CT at Cedars, and then played a central role in our effort over the last decade within the Eisner study. Alan continues to work with us actively here at Cedars in his new position, where he is interim chief in the Division of Cardiology at St. Luke's Roosevelt Hospital and professor of medicine at Columbia University College of Medicine. Alan, thank you very much for coming back to Cedars to present to us the lessons learned from the Eisner study.
Good morning, everyone. It's always a pleasure to come back here to Los Angeles, which has always been, I consider my first home. But I must admit that coming last night from New Jersey has been especially special. We've been without heat and power and gas, as you know, and since this is being televised to 10,000 people, I just want to give acknowledgement and thank my wife for letting me to come. All right, so I've been asked this morning to describe and convey what we think are the lessons learned from the Eisner trial. And although Dr. Berman doesn't like to take credit, really the very conception of this trial, bringing together all the people who worked on it, was Dr. Berman's visionary work. And at the time that Dan conceived of this trial, we knew, and this was in the late 1990s, at that point we already understood that calcium scanning was a specific marker of atherosclerosis, an indirect reflection of total atherosclerotic burden, and in early outcome studies already there was some indication that it was a prognostic predictor. During the course of the Eisner trial between 2000 and 2009, we had these series of important longitudinal studies which emphasized the prognostic efficacy of corneal calcium scanning. This is my favorite from Matt Budoff's work as he presented this morning, showing that for each increment in corneal calcium score, over the long term there's an incremental decrease in survival. Now, had these data been published 8-10 years earlier, today we would be enjoying universal third-party healthcare coverage for corneal calcium scanning. However, we know that this is not the case. In fact, we have very limited coverage, no coverage in the tri-state area in New York for corneal calcium scanning. And the reason is because at the very time that these studies were being published, we had a marked raising of the bar. It was no longer sufficient to prove that tests predict outcomes, but also we had to show that they actually change outcomes. And this is a marked change and something that we are working under now, and we have to deal with it. So in fact, now the new tests that have been developed, we have to show that they lead to decrease in risk factor profiles, decreased testing, resource utilization, and medical costs, and decrease in adverse cardiac outcomes. So this bar was not in place at the time that Dr. Berman, invented the Eisner trial, so truly it was quite visionary and timely. And the goals of the Eisner trial were to conduct a prospective randomized trial to, one, determine whether corneal calcium scanning of asymptomatic individuals leads to beneficial four-year effect on CDI risk profiles, and two, to assess the impact of corneal calcium scanning on downstream medical resource utilization and healthcare costs. Now, the design of the study was that 2,137 healthy volunteers with corneal risk factors but no clinical evidence of corneal disease were randomized in a 2-to-1 ratio, 1/3 to a no scan group and 2/3 to the scan group. Both groups underwent a one-time risk factor consultation based on age guidelines, but in the scan group, the subjects were also counseled based on the results of the corneal calcium scanning. We employed nurse practitioners for the counseling, and they were trained in impartiality and consistency in risk factor counseling. Subjects were given individually customized risk factor management packets. The calcium scans were actually viewed by the subjects, and the scores were explained to them by the nurse practitioners. and the subjects were instructed that any calcium abnormality was indicative of atherosclerosis. And per IB requirements at that time, reports were given to the subjects and sent also to the doctors of the subjects upon their consent. Subsequently, then, the subjects were followed and brought back for a 4-year clinic visit. At the time of the baseline and 4-year clinic visit, we obtained historical risk factor information. We assessed total cholesterol, LDL, HDL, and triglycerides, fasting glucose, systolic and diastolic blood pressure, height, weight, and waist circumference, and we calculated the Framingham risk score. The behavioral measurements included medication adherence, cessation of smoking, change in weight and waist circumference, and self-reported physical activity. We further assessed procedure costs and medication costs during follow-up for the 6 procedures shown here and for lipid, blood pressure, diabetic medications, and aspirin. So let's look now at the main findings briefly in the scan versus the no-scan group. So compared to the no-scan group, the scan group did show favorable changes in systolic blood pressure at 4-year follow-up, LDL, waist circumference, and weight loss, the last 2 measurements being assessed in those who were overweight at the time of recruitment into the study. Compared to the no-scan group, the scan group did not show favorable changes in triglycerides, glucose levels, smoking cessation, or in exercise activity. These changes resulted in about 0.7 increase in the Framingham risk score in the no-scan group, but in the scan group, the drop in blood pressure and LDL were sufficient to offset the increase in age, and the Framingham risk score remained flat. This slide shows the comparative tests that were performed during follow-up in the 2 groups, the no-scan group in yellow and the scan group in red. And you can see for all of our cardiovascular procedures, there was a very similar frequency of tests performed during follow-up. So in fact, when one looks at the costs in the scan and no-scan group, both for the procedure costs and medication costs during follow-up, they were comparable in the 2 groups. Now let's look briefly at the results in the scan group. So when we look at the findings, according to baseline calcium score with those progressively with a 0 calcium score in yellow and those with calcium scores over 400 in pink, one sees with progressive increase in the calcium score, there was a progressive decline in cholesterol, LDL, and triglyceride measurements at 4 years. As far as blood pressure, again, systolic blood pressure and diastolic blood pressure at 4 years felt greater in those who had evidence of atherosclerosis compared to those in 0 calcium group. Now, these changes were largely driven by the changes in medication use. So we see that with rising calcium score, there was a progressive increase in use of lipid medications, blood pressure medications, and diabetic medications. And the frequency of tests increased with calcium score, shown here for stress testing and also for the other procedures not shown here. So when one looks at the costs in the calcium group, the costs increased with increasing calcium score. And as you can see, there was a marked increase in costs in the group with a calcium score of over 400, essentially double compared to lower calcium abnormality. Superimposed here, I show the median total costs in the no-scan group during the follow-up. One can see that in the 0 calcium group, the costs were about $1,000 less during follow-up compared to the no-scan group. When you further impose here the actual frequency of the subjects in each of these groups, one can see that the calcium group with the calcium scores over 400 had only 8% of those had calcium scores over 400, and approximately half of the subjects had a 0 calcium score. So the reason why the costs were comparable in the 2 groups is that you had a small group with an increase in cost and a large group with a decrease in cost. And really, when you think about it, this starts to approximate the ideal that you would request for a non-invasive screening test, that you identify a small group at high risk where you can be very aggressive in, and a large group in which you can be less aggressive in and save costs. So, let's go. So, the lessons learned from the Eisner study include: 1, randomization to risk counseling with calcium scanning was superior to conventional risk factor counseling for inducing reduction in risk profiles. 2, this benefit occurred without increasing costs or downstream resource utilization. And 3, higher costs for the highest risk groups was offset by the lower cost for the lowest risk subjects. I think equally important is to ask what are the lessons that we did not learn from the Eisner trial, lessons that I think we can apply going forward as we try to develop new protocols here in the SHAPE deliberations and other venues. So I said that new tests under this paradigm where we have to show that they have to decrease risk factor profiles, decrease medical testing and costs, and show decrease in adverse cardiac outcomes. When you look at what are the potential drivers of this, basically it's two. Either we have to favorably change physician practice, or we have to favorably change patient behaviors. So let's isolate this question for a moment and ask, in fact, what is the potential impact of risk information on physicians and on patients? So in terms of physicians, high-risk information can impact physicians in many ways. It can cause us to be more intense with our counseling or spend more time with subjects and patients, pay more attention to risk factors and symptoms, increase our use of medications, decrease our threshold for testing, and increase the intensity and frequency of our follow-up. Now, we did not directly assess how the physicians were handling the results of the calcium scans in the subjects that we studied in the Eisner trial. But we can infer, let me go back, from the data showing this progressive increase in medications with increasing calcium score and nice progressive, decreased threshold for testing with increasing calcium score, that these were ways in which the data was impacting on physicians. Now, how high-risk information might impact on patients is a totally different matter. Ideally, high-risk information could cause patients to adhere more strongly to medications, improve their diet and manage their weight, start to exercise, stop smoking, take seriously and manage serious psychosocial stress, and overall, I'd say, increase their health proactivity. That's in the ideal. The fact is that we know all too well, as physicians taking care of patients, that too often high-risk information often, and I'd say quite often, does not lead to favorable change in health behaviors. So we have a sort of disconnect here that we commonly deal with, and there's many reasons for this. But one of the profound reasons that I would say that relates directly to the issue this morning is something that has been described well now in the psychology literature, in behavioral economics, for example, which is a new field, which is an area called intertemporal discounting. And I think this is an area that we need to consider and bring more into medicine. Basically, this concept actually represents an axiom of human behavior, which says that in the moment, there is a universal tendency for individuals to overvalue present goals and to undervalue future ones. Let me offer this by example. Let's take John, who's a very busy 55-year-old executive. He's moderately overweight. He's a smoker. Finally, he comes to his doctor for a clinic visit, has lab tests, and he's found to have a high intermediate Framingham risk score. His doctor, of course, advises him to stop smoking. Now, what actually happens in the abstract in the doctor's office? At this point, John recognizes that, his health in the abstract is more important than his work goals. And he says, I should stop smoking. And John and his doctor are both convinced after the discussion that John will stop smoking. What happens in the next day when John's back at work is that his work goals are present-oriented and his health goals are future-oriented. And so what happens is in the moment, the work feels very palpable to John. And in the moment, in that day, John says, my work's very pressing, it's very important. It assumes greater importance. At the same time, John rationalizes, smoking today won't kill me. I'll stop tomorrow. So John comes back tomorrow, the same dynamic occurs, and the next day, and then over time, the very inspiration that was induced through the doctor's physician's, advice washes off. So this is a common thing we have to deal with. The potential appeal of calcium scanning is that it has the opportunity to take something that's future theoretical risk, such as risk factors or presenting patients with a future risk of events through a Framingham risk score, and say to the patient, to John, this is present, concrete evidence that you have disease. And potentially this can be more motivating. To put this in another way, what we see with risk factors, Framingham risk score, is that we have a certain intellectual understanding of risk that with images, we have the ability to potentially convert that into an emotional reality for patients. And this conversion from an intellectual understanding to an emotional reality really is the basis for all behavioral change. But if you're going to talk about behavioral change, motivation is not the whole story. Basically, the anatomy of behavioral change is these 3 steps. You have to motivate patients, you have to get them to execute health goals, and then you have to get them to maintain them over time. Now, the point is motivation is critical for this. If people are not motivated, they won't change. But the problem is motivation is not sufficient. Psychologists understand this well. In fact, there's a meta-analysis by Sheeran and colleagues, which was published about a decade ago, which actually was a meta-analysis of 10 meta-analytical studies. That's how much psychologists have studied this issue, involving over 80,000 participants. And they found that intentions, motivation, only accounts for about 28% of the variance in the behavior of individuals relative to goals. Or as the folklore says, the road to hell is paved with good intentions. So really, you know, the other aspect of this is we have to look at execution and maintenance. That's where 70% of the variance in behavior, lies. And in fact, if you look in the medical literature, mostly in the medical psychology literature, over the last decade or so, important evidence-based techniques, many of them easy to apply, have been developed and introduced into medicine, including the use of temporal anchors, specific action planning techniques, implementation intentions, mental contrasting, self-monitoring, for example, using pedometers to get people to exercise, feedback, use of contingency plans, stress management techniques, and social support. Now, many of these techniques are not yet known in cardiology, although there was an interesting recent white paper that was published in JACC concerning this new concept of patient-centered cardiovascular care, which actually mentioned a number of these techniques. So I think this is an area that cardiology is going to grow into. But the point is not to mention these techniques, but just to mention this main point, that when you motivate patients, when you have them in the palm of their hands, when you've shown them risk information, such as all this information we've described today, if that is not anchored to action, it tends to be fleeting. Inspiration, to be lasting, has to be anchored to action. And you can reflect on your own lives where you've been inspired or not, and when did you change, when your inspiration was anchored to action. So, in summary, in the Eisner trial, in the Eisner prospective randomized trial, calcium scanning led to 4-year reduction in risk profiles without increasing costs. This effect probably occurred due to the effect of calcium scanning on physician management. Still to be tested is how combining calcium scanning with behavioral management techniques furthers the capacity of calcium scanning to improve patient self-management and clinical outcomes. So, as I've mentioned, the new paradigm we function under is not just only that we have to predict outcomes, but we have to show we have to change outcomes. Predicting outcomes falls under the arena of risk assessment. Changing outcomes falls under the arena of risk assessment. Until now, these 2 areas have functioned as independent areas, almost different silos in cardiology. If we are to maximize and harness the power of our tests to change outcomes, whether it's calcium scanning, vascular imaging, etc., we need to develop a new effective interface where we actually think of a continuation of risk assessment and risk management. In other words, I think it's a natural continuum. First we assess the risk, and then we manage it. Thank you.